Welcome everybody. There's a slow trickle of people coming through. We've got quite a lot on the webinar today. It's due to start in a couple of minutes' time. We'll just give everybody till 12:30 to log in. Hope everyone's enjoying this beautiful, sunny but freezing cold day. If you want to pop anything into the chat just to say hello to anyone, please feel free to do that. We'll be monitoring that as we go through the webinar today. So any questions or any thoughts that you've got, please do feel free to pop those into the chat, or even if it's just to say hello and introduce yourself, just pop those into the chat as well. That would be great. Okay, we are, I think we're on time now. So welcome everybody to this, one of our wellbeing series of webinars run in partnership Wellbeing Clinic Essex, and Sue, who's going to be leading that today. We've got a high activity on this one. There was a lot of interest, so lots of people wanting to be on this webinar. So the Kingswood team, Laura and Katie, will be managing the letting people through from the waiting room, and also be monitoring the chat. I will be just running through a little bit of an intro, and then I'm going to hand over to Sue. So just to say, for people who haven't been on one of our webinars before, we are Kingswood. We're Kingswood Group. We are a specialist HR and recruitment consultancy based here in Essex, but we cover the whole of England. And we provide HR advice and guidance and support to a whole range of clients, whatever the needs may be. And part of our belief is that the knowledge that we have should be shared, so that organizations and people within organizations can become as upskilled as they can possibly be. And we've had a very successful series of wellbeing events that Sue's led on, which we've got this one and then just one more to go in this series for this year. But we also have a forthcoming sickness absence management course, which Laura Wright from Kingswood Group will be running. So we'll talk more about all those courses a bit later on. So I think without further ado, I'm going to hand over to Sue, and then I'm going to put myself on mute because nobody needs to hear me chatting in the background.
Thank you, Gemma, and good afternoon, everyone. My name is Sue, and I am the medic that owns and runs Wellbeing Clinic, which is predominantly in Colchester, but all over Essex, really, to be honest. And we help people privately with their health and wellbeing. So this is one of our number of health seminars that we've got in the diary, as Gemma alluded to. And this one is always popular, and it's a topic that I'm very passionate about, which is women's health, and particularly with a focus on the workplace and the effects that that can have when it's potentially mismanaged, like it sometimes can be. But also just an awareness of how to look after yourself as a woman, but also if you're not a woman, then awareness of women's health and how, as a line manager, a friend or a colleague, you can support those women in your lives through some of the challenges that come inherently with being a woman. So the whole series of these that we're doing talk about really about how you can thrive in the workplace. So that's one of the kind of key words that I'm quite passionate about, because none of us just want to be and get by. We want to be the best version of ourselves, where not only professionally, but also personally, we can thrive as individuals in our different environments. So to look at what we're going to cover in today's session, we're going to start with a little bit of an introduction as to why women's health is so important. We're going to look at some UK statistics surrounding women's health. We're going to look at a number of very prevalent female cancers, which are breast, cervical, and ovarian. And we're going to look at the screening that is in place for those and additional screening that you can do as individuals, as well as talking about menopause and stress, which are other big areas that affect women's health, particularly in the workplace. And then we're going to look at further support options, so what you can do to gain further support should you need it. So really the rationale for this webinar is that, as some of you will know, a lot of studies and medical studies are conducted on cohorts of kind of middle-aged men, and there's not actually that many that specifically focus on women, and particularly women that are middle-aged, that may have different health conditions to a young person or a middle-aged man, for instance. So women obviously experience different health issues to men. There's a number of key differences in their physiology and obviously their anatomy. And because of that, it's really important that we focus on those differences to allow us to better support the women in our society and in our workplaces, just as it is to focus on those differences with men as well. And we do a male equivalent of this talk that focuses on some of those topics affecting men, particularly things like prostate, testicular cancer, mental health, etc. So there's some really good preventative measures that are in place and that you can do as women to look after yourself. So this really talks us through what we can do and reminds us of those and the importance of those. So statistics, just to kind of set the scene, really. And some of these are a little bit morbid, I'll be honest, starting with the first one. So 1 in 7 UK females will be diagnosed with breast cancer. It's quite a lot. It's not a life-ending illness always. It can be, unfortunately, particularly if it's not diagnosed early enough. But nowadays it's a lot more treatable, and sometimes we more often hear of more people overcoming cancer than necessarily pass away from cancer. But obviously a lot of people do still die from cancers, and that's why that early detection is so important. With regards to ovarian cancer, one of the most aggressive female cancers that there is, there's 7,400 new cases on average each year in the UK, which is about 20 every day. Very prevalent. And we'll look later at how actually the main symptom of ovarian cancer is bloating. What woman doesn't suffer with bloating? So it's so important to know your body and notice those signs and symptoms to help reduce the incidence of that, as well as the early detection. 1 in 5 women have a mental health problem, so it's not too dissimilar to the statistics surrounding men either. Going back to cancers, more than 4 in 10 cancers are preventable. So by preventable, we mean that they either didn't need to happen in the first place, or that they can be treated and prevented from becoming really sinister and potentially terminal. Obesity. So often we glaze over obesity a little bit in society because inherently we are quite a big nation. When you look at the statistics surrounding our weight in particular, and obesity does carry a lot of risks. So it's actually the second leading cause of cancers after smoking. So we all become quite familiar with, you know, what an average person looks like. But actually the average normal that has been shown in studies when people draw the average person in the UK is actually overweight. So it just shows how we normalise being overweight and obesity in our society. And yet that does have a huge cost, not just to individuals, but also to the healthcare system. So it's important to remember that that doesn't absolve you of any, I guess, problems. In fact, it causes quite a lot of problems. So also something that when I deliver this talk, a lot of women don't realise is that alcohol consumption particularly has a massive risk, not just to cancer in general, because it does, particularly things like mouth and throat cancers, alcohol causes. But with regards to female cancers, just 2 units of alcohol per day increases the risk of female cancers by 9%. And when you think of 2 units a day, it sounds quite a bit, but when you think actually that's 14 units a week, and that's what the government says is safe for women, that actually you're increasing your chance of female cancers by nearly 10%. It's actually quite a scary statistic, I think. So it's important to remember that alcohol isn't completely benign either. Much like obesity, you know, it has massive risk factors associated for it. With it. So there's some statistics there. So this is why it's so important that we're talking about this topic today and increasing the awareness. So one very common cancer that we're all probably aware of, in fact, most of us will probably know someone that's had breast cancer or died from breast cancer or been worried about breast cancer, is why it's important that we talk about that today. So Gemma, if you could just click ahead, that'd be great. Thank you. There we go. So it's one of the most common cancers in women. And the reason for that is that breast tissue changes throughout a woman's life in response to the hormones that are produced and how they change throughout a woman's life. So if you think about the journey that a woman goes on, for instance, in puberty, where they get massive changes in particularly estrogen levels, but also progesterone levels and testosterone levels, and what they do, the breast tissue responds to those. So you go from being a child to growing breast tissue to having fluctuations in hormone levels throughout the month that can change breast tissue. Some women get sore breasts around sort of time of the month, things like that. Then potentially a woman might go on to have a child or children where there's massive changes in hormone levels and the breast tissue again. And then as we age, we get that reduction in estrogen that comes with menopause and also causes changes to the breast tissue. So this tissue is having to continually respond to what is being passed around in the bloodstream by hormone release in different areas of our body. And sometimes that means that because of this continuous change, the tissue, because it's growing and changing all the time, can be more prone to mutations that can result in an uncontrollable level of cell division and consequently a tumour, whether that's benign or malignant, to form. So most breast cancers develop in the glands for that reason, because the glands are the areas that are changing most of the time. They're also much closer to the blood supply. So as hormones travel around in the blood, the glands are in closest proximity to those hormones. So they're exposed to the most concentration. And also the milk ducts, because the tissue is particularly sensitive and ever-changing and delicate. So it allows for any slight change to cause a more serious repercussion. So that allows us, when we're doing our own or patients' breast examinations, to really focus on those areas that we know are much more likely for problems to develop in. So, and we'll talk about that shortly, about how to kind of do a breast examination of yourself, usually, unless you have children or parents or anyone that is consenting to you helping them with their breast examination, then obviously it's useful for that as well. So actually, we talk about the changes that occur in breast tissue with having children, but actually having children and those hormone changes, as well as breastfeeding, does actually reduce your chance of getting breast cancer. So does also doing regular exercise, attending mammograms if you're invited to attend those on the NHS, which usually occur about the age of 50 plus. And as does self-screening help, because any early changes in the breast tissue you're able to pick up quite quickly that can lead to obviously better treatment plans in place. And as I mentioned in the statistics, a lower alcohol consumption will also help reduce the risk, as will being a good body weight. Okay, so just a question to the audience, really. So do you regularly do breast examinations? So ideally what we'd recommend is about once a month. So often I say to people, you know, on the first of the month, just make sure you do a couple of self-examinations, one of those being breast examinations, and seeing if you notice a change in your breast tissue, because you'll know your breasts from previous examinations. So is anyone up for talking about whether they regularly do breast examinations, and if so, why? At all? Or has everyone
I'm happy to talk if you like.
Thank you.
I regularly do, but I do find difficulty when around the time of my cycle, because I notice like they're more tender. So I've heard that it's probably not the best time to do your checks. Is that right?
That's right, yeah. So although I often do suggest that on the first of the month, you know, that a woman does that just because it's a reminder of, oh, it's September, you know, and you almost get that mental reminder it's a new month to do it. It's not an ideal time if it's time of the month, because the amount of estrogen that you've got and the changing hormone levels will cause a more inherently lumpy breast tissue because of the changes to the glands and the ducts mainly. So it can be quite difficult, even when I do breast examinations for people, to ascertain if there is a problem when they're on their period. Often I'll say, look, can we not plan it for that week or however long it is, just because it can create a bit of kind of confusion. So it's obviously better to do it at that time than not at all. But if you've got a way of obviously avoiding doing it at that time and having a different reminder at a different point in the month, that would be much better.
I guess it's all about understanding what's normal for you, I guess, isn't it? Getting to know what's right for your body because it's different for everyone else. Would you say that's
the
case?
Yeah, exactly that. And the thing is that although I'm trained and experienced in doing breast examinations, no one knows their breasts as well as the person, really, you know, a couple of exceptions. But mainly people know, and they'll know that, oh, there's always been a bit of a lump there, or, you know, or that's a bit of scar tissue I had from a child, or that nipple's always looked like that, or, you know, what's normal for you, it might not be normal for somebody else. So often I'll ask women and say, you know, oh, is your nipple normally inverted, or do you normally get the change in that nipple, or pucker, is that skin normally puckered under your nipple, or is that a recent change? Because one of the things that we see quite a lot when there is breast cancer is this almost kind of cellulite appearance of the tissue under the nipple. But some women just are more bumpy than other women, and for some women that's normal. So it's important to obviously understand what's normal for you and what's changed. And you're in the best place to do that. So we normally say, you know, in the shower on the first of the month, or a key date that you remember, just have a small feel around of each breast, bearing in mind to go under the armpit as well, because the breast tissue extends quite far under the armpit as well. And that's quite a common place for breast cancers. They think particularly because it is quite glandular there, and there is obviously big blood vessels there, but also because of the use of chemical deodorants and aluminium-based deodorants that have been shown to increase the incidence of breast cancers. So it is really important. Thank you on the chat for those people as well that are saying that they do the examination. The first few times you'll do it, you'll think, what am I doing? I don't really understand if I'm doing this right. But once you get to know what it feels like, then you notice if there's a difference. But there are a lot of really good resources out there, both, you know, Google images to YouTube videos. There's Breast Cancer Now. I've got a really good way, video on their site of how to do it. So there's lots of support around to help you with it. And then also with regards to mammogram appointments. So if you're over 50, normally you will have been invited to attend mammogram appointments. Sometimes we hear that women don't like them and they don't want to go to them. But sometimes we have, women that say, it's a bit squeezy, but it's not that bad. And they reassure other people. So is there anybody sort of that's happy to sort of say that they go, or that it's not that bad, or anything like that they want to share, and that might help alleviate any concerns that are in the room around that as well?
I'm an older person these days, and I go as often as they'll let me go. Don't mind getting the girls out and getting them checked, because it can be caught really early if there is some changes going on. And obviously, I know lots of people who've gone for routine checks where something has been picked up and interventive action has been able to be taken really early on. So sometimes that's big for nothing more than maybe it's just a cyst, but in other cases, it's been something more serious. So I know we sort of get a bit squeamish about having the boob squished into the machine, or maybe stripping off in front of people we don't know. But honestly, this stuff is so important, life-saving stuff, and it's available for you. So, who doesn't want to take advantage of that and live their best life? So yes, it is a bit squishy and it's a bit uncomfortable, but it's over and done with so quickly. And if it gives everybody peace of mind, it's a good thing.
Thank you. Yeah, thanks for sharing that, Gemma, because I'm not at the age yet where I've had one and experienced it. So I've seen them be done, but obviously can't talk firsthand about what that feels like. But it's nice to hear that people on the chat are saying that, they yes, it's a little bit uncomfortable, but they know that it needs to be done, and they do it with no problem. So that's nice to hear. For those of you that are sort of Colchester based, a lot of the time it is worth knowing that we work quite a lot with the Oaks Hospital. And on a Tuesday and a Thursday, they do a breast screening clinic, which is a couple of £100. But if you've ever been in a situation where you get in a frenzy because you think you found a lump, actually it's worth it for the peace of mind. And you can basically walk in on those days and have full check with an oncologist that's specific to breast, and you have all the scanning done, and then you get the answers straight away as to whether there's a problem or not. So it's much faster than the sort of NHS process, and also obviously it's much more detailed than just having a breast examination. It is actually having the screening, scanning behind that. So it's just worth knowing for you, because it's helped out a lot of my patients before when I've referred them over to there. But you can self-refer as well. You don't need an actual medical referral. Okay, so on to the next slide, please. So we're moving on to cervical cancer. So cervical cancer is cancer that occurs in the cervix of women. It's the fourth most common cancer in women, so it's very prevalent. It's what we have smear tests for in terms of early detection. And in the majority of cervical cancers, so about 90% of these cases, they're caused by the HPV, or human papillomavirus. Now, that is a virus that's now vaccinated against in the younger population, or some of you even on the call today might be in that cohort, because we're all getting older. So some of you born in the 2000s and stuff are now obviously in the workforce. So it may be that you've been vaccinated for that, which is great, because it's going to massively reduce the cases of cervical cancer. However, 10% of cervical cancers are caused by not having the human papillomavirus. And it's really worth knowing that now, as of the last few years, the NHS no longer tests for cancerous cervical cells unless you've had an abnormal smear test for HPV. So unfortunately, what that means that if you don't have HPV and you're one of the 10% of women that will go on to develop cervical cancer, it's not going to be detected in your NHS smear test, which is quite scary, and it's quite damning to obviously say that, but it is important that people are aware of what they're being tested for. I've had quite a few patients that have said to me, oh, my smear test has been normal, and they've had some of the early warning signs like bleeding after sex, spotting and bleeding between periods, postmenopausal bleeding, pelvic pain, abnormal discharge, lower back pain, and they've started decreasing what they're eating and losing weight. And I've said, you know, let's do some tests to check it's not cervical cancer. And they'll say, oh, but I had a smear test 3 months ago and it was fine. And unfortunately, it's just really important that we now know that actually privately we do cervical smear tests for cervical cancer. But unless you're from a high risk group or got the HPV virus, that's not going to be tested as standard. So it's just important that everyone is aware of that. So screening is by a smear test or what's called a pap smear, which essentially is just a small, long-shaped, almost like a cotton bud, really, that's just inserted vaginally, and it's just a small scrape of the cervix. For some women, it can be a little bit uncomfortable, but for most, it's just a little scrape and it's out and it's done, and that's once every 3 years. But that said, there are people that become very nervous or stressed about it, and sometimes that makes it harder and more stressful for people. And we have some patients that come to us and they only ever want it done privately because they feel it's a nicer experience than the NHS experience. So it is an option. So if you're one of those people that doesn't like it or had bad experiences, it is something that can be done privately at either our clinic or other private clinics, just so that you're aware it's better to do it that way than not do it at all. And the reason why this is so important is that cervical cancer is one of the most treatable cancers if caught early. So it's so treatable. The number of women that there are that you will have heard of that have had abnormal smear tests or changes to their cervix, or had cells lasered off, or had minor procedures where they've taken out some of the cervical cells or scraped a bit of the cervix off, and that has no bearing on the rest of someone's life, or often doesn't affect their fertility or anything like that. We'll all know someone that's had something like that done, and it's so treatable. But unfortunately, there are cases where people don't go to smear tests, or it's not picked up, and then they go on to die from the disease, much like Jade Goody or some of the other kind of high-profile people that have died from cervical cancer. So it can be nasty, like all cancers. So on the right-hand side there's just a picture of where the cervix is. So it's just above the kind of furthest part of the vagina, and it's literally you're just scraping on those cells. So it's not so intrusive, but obviously it is a little bit intrusive. And normally they start at about the age of 25, but you can elect to have them earlier if you've got a family history, or a reason why you're particularly worried about that, or symptoms. So that's worth knowing as well for those people that are kind of waiting until they're 25 but are worried about it. So on to the next, please. So we're going to talk about this a little bit. So do you regularly attend your 3 yearly smear test appointments? So if you're over the age of 25, do you attend? So either pop on the chat or be nice to hear you talk and tell me whether you attend and how it is.
Yes, I'm happy to talk again.
Thank you.
Yes, I feel like I had my first one a bit younger than 25. I don't know if that's if they used to do it earlier, but it was in my 20s anyway, and I have been going every 3 years, every time I get the letter. I probably put it off for the first month, but I've never really gone beyond a month overdue. But I actually it wasn't every time. It's always been the NHS, and it's never actually been as bad as what I expected. I mean, now since I've had a child as well, I don't really even think about think about it, and it's just quite normal. But yeah, I don't find it painful. If anything, I get a few period pains afterwards. And that's as bad as it's really ever been for me. So I think it's really important. I've been lucky that it's never come up with any issues for me. So but yeah, I'll just carry on going.
That's great. Yeah, thank you for sharing that, Laura. I appreciate
Okay.
that. Um, you know, as a clinician, you know, we do these all the time, and I think people can feel quite awkward about it, and it is awkward. You know, I feel a bit awkward when I go for mine, but it's, you know, you'll know from the person that they're doing it day in, day out, and it's, you know, you feel slightly like you've got one of those horrible gowns on, and then you've got to open your legs, and then it's like that weird device that always looks a bit barbaric, but actually you don't really feel it. And then it's just a little scrape and it's done, and you're off on your way, and then you get a letter. So that's sort of the procedure for those of you that haven't had one. That usually it is as straightforward as that, and then you just get the peace of mind of knowing that you don't have HPV, or that you know, most clinicians are pretty good. You know, if you went in and you had symptoms and problems, they would authorize an abdominal and pelvic ultrasound to see if there's anything going on as well. And they can also then approve that in the smear test, they test for cervical cancer cells as well. So if you do have any concerns, it's worth saying it's just not done as standard anymore that cervical cancer cells are tested for within the pap smear. So I wonder if anyone knew that in the room. Did any of you, were any of you aware of that change that happened a couple of years ago in the NHS?
No, not at
No.
all. I think my daughter's nearly 29. God, I hate to say this really, but my daughter's nearly 29. And after I had her, I didn't think I needed to have a smear test for quite some time because I thought, well, I'm being checked for all sorts of things. So if there was a problem, somebody would have told me. And 5 years on, I had a smear test done, and there were changes that were required intervention. So it was around, you know, I wouldn't say it was around the same time, but it was kind of not dissimilar to Jade Goody, who had been called in for smear tests, but didn't feel that she really needed them. And by the time she realised that there was a problem, it was just too late. So, you know, if nothing else, don't ignore the invitations like I did for a number of years. And, you know, as Sue said, you know, I think it's really important if you're not called in, you know, if you're not called in, don't be afraid to kind of put yourself forward or find another way to get it checked. You know, peace of mind is so valuable.
Indeed, yeah. And thank you for sharing that, Gemma, because I know it's sometimes not easy to share some of these personal experiences that we have. But also it was good that that was at the time where they were testing for changes to the cervical cells as well. Whereas obviously if that had happened now, my concern is the number of women that I see that think they're fine because they've had a smear test, and actually you kind of have to break it to them that, or they no longer test for that anymore. So as much as I don't sort of like the fact that I'm almost sort of slightly damning of that NHS commissioning decision, because I don't think it's right. It does save a lot of money, and I'm sure that money is being spent elsewhere. I think it's just really important that we know, because there are a lot of women like yourself that think, oh, if I'm going for an appointment, that's fine. I don't need to mention that I'm getting this bloating and this period pain and occasional spotting between periods, because it will be picked up anyway. And actually it's not, and it is important that you do tell your GP that that is what's happening, so that then they can commission like bespoke additional tests. So that's kind of a key point that I wanted to get across today. Okay, so if we move on then to ovarian cancer. So ovarian cancer is one of the most common cancers in women. It's probably one of the scariest cancers, I would say. I hate coming across someone that's got ovarian cancer. because most of the time, in 2/3 of cases, it's diagnosed too late. And then it's basically just a very fast decline after that point. But if it's diagnosed at the earliest stage, actually 9 in 10 women will survive it. But that earliest stage has so few symptoms that as women, we often disregard those symptoms and think that, oh, I'm just a bit bloated, or oh, my trousers just haven't fitted me for a few months because they've had, got quite a lot of inflammation, or they think it's a food intolerance or a bit of IBS. And then it's not until that they're getting bleeding and they're losing weight and things like that. And the bloating is so significant. You get this sort of ascites, which is a fluid that builds up around your middle. So often women will go up 1 or 2 dress sizes in quite a short amount of time just because of the bloating. And then obviously that's closely followed by obviously massive weight loss, because the bloating then pushes in on the stomach so that you don't feel hungry. You're not really able to eat much in one go. And then obviously the cancer takes hold, which causes weight loss anyway. And then the person obviously usually dies by that point, at some point within a year of diagnosis. So it's so important that we take those symptoms, particularly bloating. Bloating isn't normal. We all get bloated for maybe a week, a month maximum. But if you're persistently bloated, which is one of the key symptoms of ovarian cancer, what's called persistent bloating, as in it doesn't wax and wane, it's not worse. It's no different really at night time to what it is in the morning. So some people get bloated after dinner, and then by the time in the morning it's gone. That's fine. But if you're persistently bloated and that bloating doesn't change, that is the key symptom of ovarian cancer. And it's always worth working that out and seeing a clinician as soon as possible, if only just to be told that it's nothing. At least you've been told and not wasted that time. Only 1 in 5 women actually know that persistent bloating is the main symptom of ovarian cancer. So it's really important that health education like this today, and we're aware that that is actually quite a serious symptom of something not being right internally. Because as women, we're all very good at being like, oh yeah, I'm a bit bloated. It's been like that for a while, but I'll just push on because that's what we women do, because we're so busy and responsible for other things. So really do take that seriously. Also, if you feel full quickly, you're losing your appetite, you get any pelvic and abdominal pain, then that's also cause for concern as well. These are all additional symptoms of ovarian cancer, as well as the symptoms of other things as well. So don't worry, if you get a bit of pelvic pain, the chances are it's not ovarian cancer, but it is something to know your body for and to be aware of. And if it's happening consistently alongside other things, then definitely is worth getting it checked out. Ovarian cancer is most common post-menopause. I've only seen a few cases of it that have been in people under the age of 50. So it's actually quite rare in that case. And often there's a family history, but not always. So typically it is a condition of women over the age of 50. But that doesn't mean that if you're under 50, you shouldn't get those symptoms checked out. This is the only female cancer that there is no specific screening program for, which is why often it's not detected. So there's no mammogram, there's no smear test. This is something that relies on you knowing your body and knowing when something's not right, to go and see your GP to get this screened for and tests been done to get an early diagnosis or be told that things are okay, so that you can go off and live your life happily. So it's just really important to know that of all the things and all the appointments we have to attend as women, this isn't one of those things that's being checked out for you. This is relying on you to know your body. So that's what ovarian cancer is. And on the right-hand side, you'll see the diagram of the reproductive organs in a female. And that, as you're aware, that arrow is pointing to an ovary. So that's a woman's right ovary, even though obviously it's on the left because of the way we're looking at it. And then you have another ovary on the other side, unless, of course, you've had any, partial hysterectomy or anything like that done, and it would look differently. So that's also why there isn't a screening program available for it, because it's hard to access unless we rolled out ultrasounds or MRI scans or CT scans for people with no symptoms. There would be no way of picking it up under a screening program. So it's not sort of a health inequality. It's not that there is a way of screening it and it's not done. It's just that it's so difficult to test for that it wouldn't be economically viable to roll it out to a whole population. Okay, so moving on. So you'll probably have sensed a bit of a kind of undertone of the talk so far that I'm quite passionate about people knowing their body, knowing their numbers, knowing what's different for them. So as an individual, what that includes you taking responsibility for is doing monthly breast examinations, also knowing things like your waist measurements. So this is one thing that I'm quite passionate about, particularly for prevention of the ovarian cancer and the early detection, is that no one loves knowing their waist measurement. I'm always surprised that it's like my narrowest point, and it's always sort of seems excessive, whatever it is, 30 inches or whatever. Still feels like a lot, but it's important to know that so that you can notice a significant change in it, because it's not normal to go up a dress size in 2 weeks. It takes 3,500 excess calories to put on 1 pound. So if you're going on holiday for 2 weeks, probably the most you can put on in terms of fat is probably about 3 pounds, and that's going some in terms of your eating and drinking. Yes, people do get fluid retention, particularly with sugars and things like that. If they're having a lot of alcohol, they put on more weight, but that's water weight. That will very quickly go when you come back from holiday. But you're not going to go up a dress size for a significant period of time from eating too much on holiday. So knowing your numbers will allow you to notice any big changes to that. So my mother-in-law had ovarian cancer, and we all noticed that she'd suddenly put on weight, and she was wearing her jogging bottoms rather than her work trousers. When she got back from work, she'd quickly change, and she never used to do that. And I remember saying to her, "Oh, why are you doing that?" And she was like, "Oh, I've just put on weight." And I'm thinking, but you're eating less than normal. So why are you putting on weight? And then obviously by the time that we went through any process, unfortunately for her, it was too late. So it can be such a quick, scary cancer that just knowing those numbers for before, at a point where she was probably aware of some of those changes months before some of us noticed. So just that responsibility for knowing your body, knowing your numbers, as well as weight changes. I'm not an advocate of everyone, someone weighing themselves every week or something, because it can become quite addictive. But I would advise that you're, once a month or something like that, just aware of weight and any significant changes or fluctuations, just so that you know what's going on in your body. So regular exercise is a really good preventative measure that we can all do, not just to reduce female cancers, but for everything, whether it's cancer, whether it's other physical health, whether it's mental health, whether it's cardiovascular fitness. Regular exercise is good for us. Reducing our processed food, and particularly processed meats, and keeping our alcohol consumption to the recommended maximum or less if we can. Obviously, smoking and vaping aren't good for the body, so reducing or quitting smoking is advisable. Protecting yourself from the sun. So, it's a balance. A lot of people say to me, "Oh, do you always wear factor 50?" No, I don't always. I do, but I do think it's a balance with getting enough vitamin D and things like that as well. But on the whole, just being sensible in the sun is advisable. Practicing safe sex is also a preventative measure. So obviously with the link between cervical cancer and HPV. So HPV is a virus. It's not a sexually transmitted infection. A lot of people carry the HPV virus, and a lot of people pass on HPV to other people during sexual intercourse, but it's not something that's treated. And unfortunately, because it's a virus, once you've got it, you can't get rid of it either. There are some people that have tested positive for HPV 1 year, and then 3 years later, they're no longer positive for HPV. And that's just the weird and wonderful way that the body works sometimes. But there's not anything that we can do as clinicians to get rid of the HPV virus in someone once they've got it. So it's just worth knowing that, just because you don't have a sexually transmitted disease or your partner doesn't, it doesn't mean that you can't pass HPV to each other. Someone's just put a good point on the chat as well that I didn't mention in terms of the one of the symptoms of ovarian cancer, which is frequent urination as well. And that's because of that pressure that builds up from that ascites, that fluid buildup that pushes on your stomach and stops you feeling hungry, that also pushes on your bladder and means that you want to go for a wee more frequently as well. So thank you for sharing that. And thank you also for, those of you sharing your good sun protection factors as well that you do. That's nice to see. So these are just some of the preventative measures that you can do as an individual to kind of protect yourself and optimize your opportunities for a long, healthy life. So I'm going to touch on menopause. Obviously, we have previously done a full talk on menopause, so I'm literally just going to glaze over the essence of this, but often it does create quite a lot of questions and things, so I'm more than happy to go through them afterwards or outside of the call. But just in a nutshell, menopause typically occurs between the ages of 45 and 55. The average age globally for menopause is 55, and the average age in the UK is 51. The menopause can be different for different women, depending on their specific physiology, the hormone fluctuations, family history, stress. All of the things going on in life can have an impact on your menopause experience. So there's what's called perimenopause. There's also premenopause before that. There's menopause and postmenopause. So it's quite, a big area in terms of lifespan of someone and the number of years that can take up. The average journey of menopause is 10 to 15 years for pre to post menopause. So some women do just go through it overnight, but the average journey is kind of a 10-year process of hormonal change that can or doesn't always cause symptoms in someone. And the most common symptoms of those, although there's 50 odd different possible symptoms, the main ones are hot flushes, night sweats, mood changes, brain fog, and that can also cause a bit of kind of anxiety or mood changes as well. So often that's what women report or feel like they're just being quite tetchy and things like that. They're all possible symptoms of menopause. It's worth knowing there are also symptoms of other things. I see a lot of women that are convinced that they're going through menopause, usually at about the age of 42, and we do some blood tests and things like that, and it's, anemia or vitamin deficiency or a thyroid problem. So it is important not to self-diagnose that it's menopause and rule out other medical causes first, because they do mimic very similar symptoms to those. There's a lot that can be done to support a woman's menopause journey, not just HRT. There's also a whole host of psychological support and interventions and herbal and remedial and plant-based estrogens that can help. So there's lots that can be done. So a lot of people sort of have their ears closed off to sort of HRT or have their own apprehensions because of previous thoughts about it, which have now been proved wrong. But that does sometimes scare people. So it's worth knowing. It's still worth talking to your clinician about, even if you're not up for HRT. But there are so many different types of hormone replacement therapy now. I have some women that are just on testosterone. I have some women that, you know, just on estrogen, and they have the Mirena coil, or lots of different ways of getting both types of hormones, as in estrogen and progesterone, into women, whether it's gels, whether it's sprays, whether it's orals, whether it's vaginal pessaries, or testosterone gel. There's loads of different options. So it's not a one size fits all. If you've tried one and it didn't work, there's others. So it's just worth knowing. So that's probably the quickest I've ever talked about menopause. But does anyone want to say about how they found the menopause journey, whether they've tried HRT, whether they're worried about it, anything like that they want to add?
I don't mind sharing that I actually have had a surgical menopause through having a hysterectomy. So I was kind of just hit with it, really. And I can't take HRT as well. So I have to kind of use alternative ways of like coping, which I found like yoga really helpful, kind of practicing mindfulness and having like a healthy balanced diet have helped my symptoms, as well as I've just probably been taking it for about 6 months to help with my sleep, is magnesium glycemate. It really helps with like anxiety and helps with my sleep and my restless legs. That was my biggest symptom, just the achy restless legs at night that would keep me awake. So yeah, so there's plenty out there if you can't take like HRT. There's other alternatives. It's just kind of finding what works for you, really.
Yeah, absolutely. Thanks for sharing that, Katie. Yeah, we have a nutritionist that works at our clinic alongside the private GPs, and she'll help on a nutritional basis for women that don't want to or can't take HRT. So there is so much. So thank you for sharing that. And magnesium can be a game changer, can't it, for people? So thank you for sharing that as well. Okay, so I'm just mindful of time. So we're just going to move on to the last topic, which is stress. And again, I'm going to kind of glaze over this, but just give you the essence of it. And the reason why it's important within this presentation is that a woman's stress response is very different to a man's, as those of us that are in relationships with men can probably attest to. So we have a completely different hormonal system, and that causes us to react more emotionally to situations. And consequently, we're more likely to become exhausted from stress than a man is. And stress can cause constant fatigue, sleep problems, irritable bowel syndrome, hormone imbalance, headaches, migraines, and burnout. And it can, as Gemma will tell you shortly, have serious manifestations in the workplace. And that can often lead to people going through times where they're signed off sick and trying to come back to work, and sometimes just feeling like they've been off too long, that it's just easier to throw the towel in than come back. So it can be really difficult for people. They're going through a stressful time anyway, and then they feel like they've got to leave their job or something because they feel a stigma's attached to it. So it's all very exhausting. And I think one of the best ways of kind of preventing that from happening to you or your colleagues is to really notice the stresses that are flowing into somebody. So have they got a lot on their plate? Is workload heavy? Have they got issues at home? Have they got family health problems? Have they got things that are just getting on top of them? Injuries, whatever it might be, they might just have a lot going in. And then in terms of outlets for that, some people have got, you know, holidays booked, they have nights out with friends, they have exercise classes that they attend to, and all this stuff that helps balance it out. But if, very simplistically, you've got more going into your stress bucket than you've got outlets coming out to release that pressure, the bucket will combust, much like a person will feel that their brain is busting when they're going through periods of stress and burnout. And so it's really important to help ensure that that doesn't happen to you and others by sort of saying that you're noticing that and then putting measures in place to help them to address that. And if stress isn't treated quickly or addressed quickly, it will turn into anxiety, and that anxiety will turn into depression. It's just the basics of physiology in terms of how a prolonged period of stress affects our body and what that results in. So I think that also helps to take away the stigma around mental health problems when we know that actually stress will cause, if it's not dealt with, anxiety, and anxiety will lead to depression, no matter how resilient a person you are. If it's not dealt with, it will get to that stage. So that's just worth knowing. So that's a bit on stress. So on to the next slide, please. So just a little summary to recap. We've talked about how women's health is different to men and the reasons for that in terms of different physiology and anatomy and hormones and things like that. We've looked at some of the UK statistics surrounding particularly the female cancers, but also around mental health and health inequalities and things like that. We've looked at breast cancer, cervical cancer, ovarian cancer, and we've looked at the screening and preventative measures that are in place to help us spot those signs and symptoms or help clinicians to detect those. And then we've also covered menopause and stress, which are some of the things that women have to also experience throughout their lives as well. So I really tried to make it quite an all-encompassing talk around women's health. Apologies that it was slightly rushed at the end for those two topics. But I hope you've gained some valuable insight into some of the main topics affecting women. And I'm just going to see if there's anything else for me to, nothing else for me to say apart from questions, and then to hand over to Gemma to say a bit about how this fits into Kingswood Group. So any questions on any of that before I hand over to Gemma?
Might be quite nice if we could unmute everyone. Or anybody who'd like to speak, feel free to unmute yourselves. I have a question about post-menopause, being as I'm a slightly old person as well. Post-menopause, what sort of time frame, she said, asking for a friend, what sort of time frame does that go on for? How long does it go on after menopause itself?
What was the first bit, Gemma? How long does what go on?
How long does the sort of post-menopause phase last? Is that, I mean, you're obviously post-menopausal till the end of your days.
Yeah.
But with getting symptoms, etc.
Yeah, so post-menopause is typically a third of women's life. But actually, post-menopause is defined as the period of time after menopause where you're not getting any symptoms of menopause. So actually, if you're still getting symptoms of menopause, you're not yet post-menopause. So post-menopause shouldn't be a difficult time, but it is a time where if you've got, which you will have unless you're having HRT, low hormone levels, it might continue to have effect in terms of, brain fog, bone density, memory, those kind of things. But it won't be as acute as things like night sweats, hot flushes, irritability, those kind of things.
Thank you. Any other burning questions out there? I've gone very silent. You've given them so much information, so much food for thought. So
yeah, that's what it is.
Okay, well, sort of say alert to the time constraints. We will just kind of wrap things up, and I'd like to extend a huge thank you to you as always, Sue. You're a fount of knowledge and insightful, thought-provoking ideas, really, about not just all the doom and gloom stuff, but how we can sort of take preventative measures to keep our health and well-being on point. And obviously, the health of people, women and men in the workplace is absolutely critical, because, we need people to be well so that they can come to work, do the jobs that they're paid to do, and all the obstacles and the trip hazards around health can get in the way of that. So if you are in a business where you have experienced or are experiencing some challenges around managing people with health conditions, or you've got people who have got long-term sickness problems, or you need some guidance around menopause policies, or you just want to have a general chat about what you're doing and whether that is enough or whether you could do more, then by all means do feel free to get in touch with us at Kingswood. We work really closely with Sue, so if it's something that's very specialist, we will always refer on. You can always get in touch with Sue at Wellbeing Clinic direct. Just would like to thank everybody for participating in today's event. Remind you that we've got 2 more events this year. We've got one in October called Managing Sickness Absence, Getting It Right. And that's part of our employment law series, so very much targeting our how to make sure that we're doing things without causing major problems in the workplace. And then the last in our wellbeing series with Sue for this year anyway is the men's health, which we've already got quite a lot of subscriptions for both of those actually. So if you do want to attend either of those, please do jump to our website, kingswoodgroup.org, and find our news and events and book yourself a free place. So for now, it's just to say thank you, Sue. Thanks, Laura. Thanks, Katie, for your support. And just thank everybody for attending. And we hope you have a lovely rest of the day.
Just a question on the chat, Gemma, if I may.
Oh, sure.
That's all right. So somebody has asked, when we go for a smear test, can we ask for the cervical check as part of it too? So you can ask to have cervical cells detected, but it really is down to the GP as to whether or not they will do that. So if you had symptoms of potentially cervical cancer, then the chances are they would do it. And if you had a family history, but if it was just a request for it, it's unlikely. But if you don't ask, you don't get. So it's worth a try. So yeah, I hope that's helpful. And yeah,
and I'm guessing they can always come to you, Sue, and speak about, getting some signposting where they can get checks and things done.
Yeah, so we can do a cervical smear test for HPV and cervical changes for £200. But normally what we advise is if someone's had HPV tested on the NHS, that we do just the cancerous cells part, which is about £120. So, and you only have to do that once every 3 years. So although it's quite a bit of money, if you average it out, it's not that much. Yeah.
Good investment for peace of mind, for sure.
Indeed, yeah. And yeah, thank you for everyone for saying thank you. That's very nice. And there was a lady that joined from the US, so that's lovely as well. So thank you.
We are going to be putting the webinar up on our website. So anybody who was signed up today and wasn't able to attend, they should be able to see it there. And we'll be sending out slide decks, etc. So yes, just thanks everybody, and have a fabulous rest of the day.
Thank you.